It's always my pleasure to be with you. India is one of my favorite destinations. I have too many friends in India. I always like to come every now and then. In this talk, I'm going to share with you my experience with the toric ICL, and my point of focus here is when do we use toric ICL? I'm consulting for Star Surgical, manufacturing the ICL. And if we go back 10 years ago, or almost 10 years ago, when the toric ICL was introduced in 2003, that's 12 years back, before having the toric ICL, the indications for phakic lenses in general were a little bit different. We are doing phakic lenses for those patients who cannot have LASIK or SMILE now. We were doing phakic lenses when we cannot do LASIK or when there is really a high suspicion for developing ectasia. When the toric ICL became available, things a little bit changed because now we can correct the astigmatism. And as I'm going to show you in a few minutes, the number of patients, the percentage of patients who need to have their astigmatism corrected with refractive surgery is more than 70% or 80%. So imagine if you have an excimer laser that does not correct the astigmatism, or a SMILE technique that cannot correct the astigmatism. It's not good for refractive surgery. That's why having a toric design is prime importance for any phakic IOL to survive or to be in use. So once the toric ICL became available, it changed the indications for phakic lenses. So today, anybody who has myopia of 8 diopters or more is an ICL patient. I do not do any kind of laser vision correction for these patients. Anybody who have myopia between 6 and 8, I would rather do an ICL than doing any kind of laser vision correction, because I know that the visual quality is much better with phakic lenses, simply because you do not change the cornea at all. More indications are for patients with low myopia. Now in my practice, I see more and more patients who just come and want an ICL because their brother, sister, friend had an ICL and are very happy with -3 or -4 diopters of myopia. So they come and ask for ICL. So patient preference is an increasing indication in my practice today. Anybody with thin cornea, with suspicious topography, with a family history of keratoconus, to me, is today an indication for toric lenses. Now, when to use toric lenses? If we have an astigmatism that is 1 diopter or more, I use a toric lens all the time. Now, when I look back on my more than 500 eyes with ICL, and I wanted to know what is the rate of ICL to toric ICL in my practice, and I was surprised to see that I'm doing relatively more toric ICL than ICL. It's like a 50-50, but more toric ICL than ICL. And then I went back to these patients and I looked at the distribution of the preoperative cylinder. And I found that only 4% of my patients have no cylinder. 38% in round figures, they have cylinder less than 1. Well, I would say it's always, you don't have to correct astigmatism if it's 0.5 or 0.7. We know this from our experience. More than 30% of my patients have cylinder who have 2 diopters or more. Of course, you have to correct this with a toric lens. Now, the question remains, if you have a cylinder between 1 and 2, would you go for a toric or a spheric ICL? This was a big question, the gray zone, the debate. In my hands, I would go for toric ICL even for a 0.7 diopter of astigmatism. So I wanted to look at this area. How are these patients doing after ICL versus toric ICL? So I got retrospectively, I studied 2 groups of patients who are relatively moderate or low myopic with a spherical equivalent up to 7, so they are moderate or low myopes, with a low cylinder between 1 and 2. I wanted to see how these patients did 6 months after the surgery. A group of these patients had a spheric lens, no toricity, and the other group had a toric ICL. Now, if you're going to look at the spherical equivalent, it's perfect on both sides because you're doing a spherical equivalent analysis. But it's more important to look at the vector analysis. Here you see on your right-hand side, on your left-hand side, the preoperative plot of the about 36 eyes with low cylinder. On your right-hand side is the double-angle cylinder plot 3 months or 6 months after spheric ICL. You can see there's a little bit of change, but not that much. The spherical equivalent is almost zero, improved totally, but the cylinder did not change much. Now, if you look at the toric lenses, the same refraction, the same average cylinder before the surgery, between 1 and 2 diopters of cylinder, spherical equivalent less than 7. On your left-hand side is the preoperative plot, and on your right-hand side, 3 months after toric ICL. And you can see the big difference in the correction of the astigmatism only if you look at the vector analysis. For any serious analysis of astigmatism, you have to look at your vectors. And so you'll not be surprised if I tell you that the patient with toric ICL had significantly better uncorrected vision at 3 months after the surgery because they have their astigmatism corrected. Now, what about the stability? It's important to have a stable lens inside the eye if you're going to correct the astigmatism. That's why any lens that rotates in the eye cannot have a toric design. So I was very much concerned about the toricity, or about the stability and rotational stability of toric ICL when I started doing this more than 10 years ago. So for many years, I was doing this OPD scan analysis for all my toric ICL patients, looking at the toricity inside the eye, of the lens inside the eye. So I found that if the lens are properly sized, if the lens is not undersized, they never rotate inside the eye. You can have the toric lens rotated if, and this is more common, if you do a surgical misalignment. And the more common reason for this is a small pupil during the surgery, so you cannot see your alignment mark. Late rotations is rare, but it can happen if you have a small lens, an undersized lens. So my indications, some surgeons are doing spheric lens with a LASIK or an astigmatic keratotomy oversight. They call this bioptics. That was a great procedure for the mid-90s, but today I see no place for bioptics unless the error to correct is higher than the power range of the ICL. Why is that? Because doing bioptics, you're compromising your predictability. The wound healing is different. There is individual tissue response with the laser correction. And we know that the lenses have a higher predictability. You're adding potential complications, more risk with the flap, with the ectasia, with irregularity of the cornea. Also, if you have multiple optics in the eye, then centration becomes a challenge. And this shows you how 0.25 millimeter of decentration can induce lots of coma aberrations. In suspicious cornea, you cannot do bioptics, you cannot do laser correction, you cannot do astigmatic keratotomy on these patients. Otherwise, you'll be faced with ectasia post-operatively. So, bioptics carries some unnecessary risks, more surgical sittings, more complex nomogram. You have to include all these nomograms with the femto AK or the AK with the ICL. Otherwise, you have to space the procedures. The quality of vision is definitely less when you are treating the cornea, and it is not reversible. So to conclude, I believe that toric ICL, they have excellent predictability. This is already proven. Rotational stability is already proven. There is no point to add additional risk for the patients, except if the error to correct is beyond the range of the ICL or toric ICL power. And I thank you for your kind attention.